Hello, I'm Eleanor Kenny, and I'm the clinical nurse specialist for palliative care in the Fredericton and Upper River Valley areas. I also chair Horizon's Palliative Care Network, which provides me opportunities for engagement with palliative care teams across all of Horizon. In addition, I'm heavily involved in several provincial palliative care working groups intended to strengthen palliative care for all New Brunswickers. When I was asked to create this presentation, there were so many ideas that ran through my head. I wanted to produce something that would hold your attention, not be too lengthy, and offer the opportunity for some engagement as well. I had several options available to me, some very specific related to symptom management and focusing on end-of-life care. But I needed to reel in those ideas. So I thought back to my days as being a UNB instructor when I would bring nursing students to a palliative care unit at the DEC as part of their acute care experience. My students would consistently express a few things that really helped guide me in creating the outline for today's presentation. I used to get questions like, what if I say the wrong thing? What if my patient has no visitors? I wouldn't leave my loved one's side. Why aren't the physicians addressing such and such in terms of symptoms? These questions, combined with the curriculum used when I teach LEAP, which stands for Learning Essential Approaches to Palliative and End-of-Life Care, and is really the standard for palliative care education across the country, helped me land on what I think are some really important foundational elements to help you build a strong practice when caring for palliative care patients. While we meet today on a virtual platform, I would take a moment to acknowledge the importance of the lands which we all call home. So we respectfully acknowledge that the land upon which we gather is the traditional and unceded territory of the Wolastoq people. Their ancestors, together with those of the Mi'kmaq and Passamaquoddy nations, entered into peace and friendship treaties with the British Crown in the 1700s. We're committed to building respectful relationships with Indigenous peoples. We're grateful to be living and working on this land, and we're committed to learning more about the history and culture of the Wolastoq Nation. So this presentation will include 5 fairly broad topics for you to consider. First, we'll try to define palliative care. There are so many myths out there surrounding palliative care, and most of which suggest that it is simply end-of-life care. I'm hoping it will be clear by the end of today's presentation that this is not the case. Next, it's important to consider how past experiences can shape your future experiences. We'll do a short exercise to help you understand your own thoughts, values, and beliefs, and how integral that is to helping ensure that they don't interfere with the care you provide. As in any realm of patient care, cultural sensitivity is also of great importance. We'll talk about some of the things that can help you create a culturally safe practice, further ensuring that your own biases don't interfere with the care being provided to patients as they progress through their illness journey. We'll also talk about the team and initiating a palliative approach to care. And finally, I'll introduce a tool that can help you navigate through difficult conversations with patients and families. So palliative care can help more people than you might think. Palliative care can help people with serious illnesses, regardless of their prognosis. It supports caregivers and families who are caring for a loved one with a serious illness. It can also support those who are grieving and living with loss. It's so much more than just end-of-life care. Palliative care improves the quality of life and reduces suffering for people with a life-limited illness. Life-limiting illnesses are serious illnesses that could shorten life and cause death, and they have a big impact on health and quality of life. Quality of life is also a very subjective concept. It's what you define as well-being for yourself, and this includes your comfort, but it also includes the experiences that are important to you and your ability to enjoy them. Palliative care is whole person care. Illness affects many aspects of a person's life. Palliative care provides support for pain and other symptoms, emotional and mental health, spiritual well-being, and practical needs for daily life. Serious illness affects families and other people who are important to patients. Palliative care also helps caregivers. If your illness leads to death, it also supports your loved ones with their grief. Palliative care is for any stage of illness, whether it's cancer or non-cancer diagnosis. It helps people to live as well as they can throughout their illness. The earlier you receive palliative care, the more it can help you. Palliative care is not based on stage of illness nor on a prognosis. For some people, palliative care is helpful as soon as they find out they're sick. You can get palliative care while receiving other treatments. Palliative care is especially helpful when someone is in the last years or months of their life. Unfortunately, sometimes patients are very young, and palliative care is also applicable to them. End-of-life care is a small part of palliative care. At this point, I'd like to share a short story about how my past experiences have shaped the ensuing years of my nursing practice. So in the early 2000s, I was a nurse working on an internal medicine floor that provided care for oncology patients, among others. Just after lunch, I got an admission into one of the private rooms on my assignment. Jim was a man in his early 60s who had just received his first treatment for his metastatic lung cancer. He was accompanied by his wife, and when I look back, it was so obvious that this couple was completely overwhelmed with his health situation. His cancer was newly diagnosed within the last month. He was a mechanic who was looking forward to retirement in the next 2 years. His wife had just retired from a provincial government job. They had 2 daughters who both lived out of province. This was absolutely not where they expected to find themselves at this point in their life, literally fighting for Jim's life. It is unusual to be admitted for your first round of chemotherapy, but Jim was very thin, really cachectic, really, and quite frail. He'd been feeling unwell for several months prior to his diagnosis, but he was never one to complain and didn't seek the advice of his primary care provider. Jim's tumor was quite aggressive and positioned very near to his superior vena cava. His prognosis, even with treatment, was in the order of a few months. However, Jim was unaware of his prognosis, and he was a full code. And I'm not passing judgment, but it didn't seem like the oncologist had been upfront and honest with Jim. I could tell at first glance that I would not be surprised if Jim died in the next 6 months. As I was finishing his admission history, Jim noted that he felt a bit nervous. He felt a bit nauseous. I left the room in search of an antiemetic and a kidney basin. As I arrived at the desk, his call bell was ringing, and I noticed his wife coming down the hall. Jim wants to go to the washroom. He's going to be sick. I abandoned my quest for an antiemetic and headed back to the room where I found Jim already making his way to the toilet, IV pole in tow. Just as I got him situated on the toilet, he vomited for the first time, a large amount of bright red blood, and it just kept coming. He was retching and vomiting blood over and over, and I'll never forget the look of fear in his eyes, nor will I forget the terror on his wife's face as she stood at the doorway of the room watching this unfold. I was helpless and horrified. I rang the bathroom bell and my colleagues called a code. He was still breathing, but it was obvious that would not be the case for much longer. I stood there beside Jim in the bathroom as he sat on the toilet, and I just rubbed his back. He asked me to help him over and over. All I could do was provide false reassurance that everything was going to be okay. As is usually the case, the code team arrived in the blink of an eye, and we managed to get Jim into the bed. Once the attending physician heard the history, he immediately stopped the code, and Jim was pronounced dead. Of course, my colleagues cleaned Jim up, and I provided support to his wife while we waited for the social worker to arrive. We helped her call her daughters and provided her with some time to spend with Jim, who did look peaceful at this point. So this experience has had a huge impact on the way I practice once I got into this role as clinical nurse specialist. And prior to this, I was an educator, and it influenced that as well. I think it made me more empathetic, definitely more engaged in pursuing difficult conversations and advocating for honest communication with patients and families. I find it extremely rewarding to work with patients as they pursue better quality of life through symptom management. I also feel responsible as a CNS for the development of programs and policies that will have a positive impact on the patient and family experience. So this experience certainly could have given rise to more negative consequences as well. Oftentimes, our experiences can lead to us wanting to avoid situations. Maybe we over or undertreat patients after we've had some trouble managing their symptoms. Maybe based on our experience, we provide false hope. Maybe our experience was so full of emotion that we feel burnt out. So as you can see, your experiences can have a huge impact on your practice. So I know we're virtual, but I think I'm going to ask you at this moment to take part in a small reflection exercise. So I'm going to invite you to take a few minutes to reflect on one of your own experiences. And this is an experience of your choosing. Just find a comfortable position, close your eyes if you'd like, and take some deep breaths and relax. I'm going to ask you to think back to an experience that you may have had with someone with a life-limiting illness, or maybe it was someone at end of life. It might have been a patient, but maybe it was a family member or a friend. So remember that reflections can sometimes stir up strong emotions, so I don't want you to be surprised if this exercise makes you a bit emotional. As you reflect on your experience, visualize it and ask yourself, how did I feel? How do I think the other person felt? What made me feel the way I did? How did it affect me? And how has it influenced my practice and as how I care for persons in similar situations? I'm going to put my timer on for 2 minutes and we'll just sit here in silence while you think about your situation. So I hope that gave you an opportunity to really think about a patient that maybe has influenced how you go about caring for all of your patients now. Reflection, and I can't believe I'm saying this because as a nursing student, it was always the bane of my existence when I was asked to reflect because we seem to be asked to do that so often in nursing school. But I now understand the power of reflection and how important it can be. So reflection can lead to better self-awareness. Being self-aware helps you become a more effective care provider. So it helps you to be more compassionate and empathic. It helps you to remain unbiased and objective. It makes you a better listener. It makes you respond to patient stories and experiences better. And it actually causes less harm to ourselves as well. Self-awareness influences how we approach, or maybe sometimes don't approach, patients and families, and how we interpret and react to their stories. It really affects our own well-being. Being conscious of our own feelings and trying to understand what prompts them is important. What are our own fears? What provides our own lives with meaning? Some situations might remind us of our own suffering, either past or present. Perhaps it reminds us of our own mortality when we become fearful. Studies have shown that self-awareness helps us maintain work-life balance, which is related to resilience. Other factors related to resilience are laughter, humor, self-reflection, insight, spirituality and beliefs, and professional identity. Self-awareness helps us recognize our biases, and as such, allows us to learn the skill of bracketing. I'm not sure if any of you have ever heard of bracketing, but bracketing acknowledges our biases, assumptions, attitudes, beliefs, and values, and allows us to intentionally set those aside while we're interacting with patients. So this is a final, really short story that I want to share before moving on to the next part of the presentation. And I like to entitle it, Make a Smaller Ripple in the Energy of the Room. And I think you'll understand why when I get to the end of it. So in nursing, we often get caught up in checking things off our lists. We're in a rush to do all the things that are required in the run of our shift. This rushing was brought to one nurse's attention after she barged into a patient's room and hurriedly took vital signs and asked all the important assessment questions. The patient's daughter brought to her attention that as people approach end of life, it's important for there to be calm and quiet so that ancestors can come and accompany their spirit to the other side. So this was part of the patient's culture understanding. It's what was important to them. So afterwards, the nurse reflected on that and her behavior and the way she approached patients, and she became more intentional in her practice. So now before she goes into the any patient's room, she stops and takes a moment before entering the room quietly. It's like she checks the chaos of her day at the door. She pauses and pays attention to what's going on in the room. She took the daughter's advice, and now she makes a smaller ripple in the energy of the room. And I like to share that story as I find it's a very powerful message for us to learn from, and what can become what can become a very task-oriented profession. So I'm going to move on, and we're going to just think a little bit about culture. I think culture has long been misunderstood, a lot like palliative care itself. It's usually equated with race and maybe sometimes religion. Full disclosure, I couldn't think of a succinct way to describe New Brunswick culture, so I asked AI and was provided with the following description. From a New Brunswick perspective, culture is defined through a unique blend of Acadian, Anglophone, Indigenous, and immigrant influences, shaped by the province's bilingualism, rural roots, and deep historical ties. Some key cultural elements in New Brunswick is that New Brunswick is the only officially bilingual province in Canada, recognizing both English and French as equal. It has a strong Acadian or French-speaking population, which defines much of the province's culture, especially in the northern and eastern regions. In the south and west parts of the province, British Loyalist heritage remains strong, influencing architecture, customs, religious traditions, and local governance styles. The Mi'kmaq and Wolastoq nations have deep cultural and spiritual roots in New Brunswick, and their traditions, language, revitalization efforts, and art are increasingly recognized as key components of the province's identity. Fishing, forestry, farming, and a strong sense of community define many rural areas. Storytelling, local music, and cuisine reflect this connection to land and sea. While historically rooted, New Brunswick is becoming more diverse, with newcomers from Asia, Africa, and the Middle East contributing to the evolving cultural mosaic, especially in cities like Moncton, Fredericton, and St. John. In short, New Brunswick culture is a living tapestry woven from centuries of coexistence, resilience, and pride in both heritage and diversity. I'm not really one who's very good at short answers, but the message I'm trying to convey is that culture is complex, and it would be impossible for any of us to know everything about another person's culture, and nobody expects that. If you think about that New Brunswick definition of culture and how families become intertwined with one another, you can see that pieces of traditional cultures are blended with new cultures, and so it is very complex. I would recommend that you try to make it a habit to learn about your patient on a deeply personal level. Ask, are there any traditions or non-traditional things you would like to do as you approach end of life? Ceremonies, rituals, family traditions. Don't make assumptions, for example, that because your patient has Indigenous roots, they will require smudging. Patients can be spiritual or religious or both. If they are religious, there are many variations between and among religions, and you don't have to know them all. Again, this is something that you can ask about. Grief has cultural differences as well. Everybody grieves in their own way, and there is no right or wrong way to do it. I recently attended a presentation related to AEI, and one of the most poignant messages that I got from that is that I am not you, and you are not me, and we all experience things differently. So we need to really understand that everybody has a different way about going about things, and the best way to understand that is to ask people for them to share it with you. So let's just pause for a minute and learn a little bit about Gina. So Gina's 34 years old. She's had asthma since she was a child, and she was recently diagnosed with COPD. So looking at this picture and the little that you know about Gina, how would you care for her? And what things shape your thoughts and feelings about her? So to me, it looks like Gina's smoking. Kind of makes me think that maybe, getting COPD is her fault. She already knew she had asthma. Why would she be a smoker? Which obviously would not be healthy for her respiratory function. Did anybody think, I wonder why she smokes if she had asthma since she was a child? Is she the maker of her own destiny? This is one of those points where I need to remember that I am not her. I have no idea what goes on in Gina's life. The only thing I really know about Gina is her age and that she had asthma since she was a child. I don't know how severe that asthma was. I don't know what her social situation is. I don't know what her coping mechanisms are. I don't know anything about Gina, really. But I do know that sometimes, and we can't help our thoughts and feelings, sometimes we think, well, maybe, she was a smoker, so maybe she doesn't deserve the same care as somebody who contracted COPD and was not a smoker. I think the smoking piece informs our care plan. So we need to think about things like nicotine replacement. We need to provide education about the impact of smoking on her condition. But it really shouldn't impact the care that we provide. And I'll ask you this. I suggested that Gina was smoking, but did anybody consider that maybe this is a smudge? And if in fact that is what's happening and she's participating in a smudging ceremony, does that make you feel any different about her? Again, none of these questions have answers. These are all things that we just need to think about. And I wanted to take it as a simple exercise to bring you back to thinking about your biases and your judgments and your own values and beliefs, and pointing out a time when the practice of bracketing would be very effective. So regardless of what you think of this situation, of what she's doing, why she's doing it, you need to put all of those things into brackets and put them aside while you provide non-judgmental care to this patient. I think maybe by now you should be getting a sense that being aware of things about yourself is really important when caring for palliative patients. I'd say for any patients, really, not just palliative patients. So I'm just going to jump ahead for a minute, or maybe it's a reminder based on what we defined as palliative care earlier. But palliative care is not a place or a diagnosis, and it's not only end-of-life care. Consider exactly whose responsibility is palliative care. Is it the family doctor, the oncologist, the cardiologist, the nephrologist, the nurse, the social worker, the palliative care specialists? Hopefully, the next few slides will help us get a sense of the answer to this question. Let's review a bit of theory, if you will, regarding palliative care. We're going to have a look at illness trajectories, when palliative care should or could be introduced, and who and how it is introduced. So most people have some insight into the fact that they are going to die based on having some sort of illness. Only 10% of deaths in this country are sudden or unexpected. The other 90% of people have a bit of insight into the fact that they have an illness that has a high probability of ending their life. So the blue line on this, the dark blue line on this graph represents the cancer trajectory. So patients who are on a cancer journey follow a more predictable path than most other disease diagnoses, with a progressive decline in functional status and a more rapid decline in the last weeks. Organ failure is represented by the red line, and as you can see, it follows a much more erratic decline. So these are conditions like chronic lung disease, like chronic obstructive pulmonary disease, heart disease, like congestive heart failure, liver disease, chronic kidney disease, general neurological diseases like motor neuron diseases, Parkinson's, and multiple sclerosis. So in these situations, the patient experiences a gradual decline over months or even years from the time of diagnosis, including when there are signs of disease progression. The decline is punctuated by occasional crises that reduce the level of functioning. For example, pneumonia in a patient with advanced COPD or atrial fib in a patient with heart failure. Treatment helps manage the disease, but the person does not necessarily return to their previous level of functioning. So that was the red line. And then the green line is representative of the dementia or frailty journey. The prognosis is particularly difficult to establish because the course of the disease is very long. You can see that there are occasional episodes of decompensation, but these are often not as pronounced as with terminal organ failure. So palliative care, it's everybody's business. Palliative care, as I described earlier, is interdisciplinary care, and it's based on the patient's entire circle of care. It's inappropriate and absolutely impossible for all palliative care to be led by specialized palliative care teams. It really requires all clinicians to share in the responsibility. So this is just a pyramid which is used frequently in the palliative care world that kind of shows what I've just said in words. And down along the bottom, you can see that it's not just inpatient care, it's community care, it's long-term care, it's, wherever the patient finds themselves, it still requires involvement of the entire healthcare team. So I hope it's becoming clear that palliative care is not a place, not a diagnosis. There's not a switch that goes on indicating that the patient is now palliative. It's more of a philosophy or an approach to care. Early palliative care is sometimes met with resistance because of all the reasons we talked about earlier in the presentation. Many people equate palliative care with end-of-life care. The word has a negative connotation for patients, families, and even some healthcare providers, kind of considered the P word. In a study by Zimmerman, published in the Canadian Medical Association Journal, it highlights that this misperception leads to missed opportunities for patients to benefit from the approach, which is really simply good care. From a personal perspective, I've always found that palliative care allows me to practice nursing care in the way that I was taught in school. It's almost idealistic care. It's good, holistic patient and family-centered care where I'm able to meet the patient's basic needs, symptom management needs, and spend time getting to know the patient and their family, which allows me to meet many of their psychosocial needs as well. The Zimmerman study continues and finds that compared to late referrals, patients with early palliative care referrals have less depression and anxiety, better quality of life, and they can survive up to 3 months longer, which doesn't seem like a long time, but when your death is foreseeable and you get an extra 3 months, that is an eternity. We don't shy away from using the term palliative. Truth be told, we may on occasion add the word supportive. So supportive palliative care can be provided alongside life-prolonging and disease-targeted treatments. It's never an either-or decision. Patients and families can walk two paths at the same time. And this is depicted in the top graphic on this slide, where you see that life-prolonging and curative treatment starts out having a huge role, with palliative care having a very tiny role, and then that shifts as people progress through the illness continuum. So I'm suggesting the use of the surprise question, which is a simple tool to determine if patients could benefit from palliative care. When patients are diagnosed with a serious or life-limiting illness, ask yourself the surprise question: would I be surprised if the patient dies in the next year? If the answer is no, I would not be surprised, then the time is right to initiate a palliative approach to care. And so let's talk a little bit about what a palliative approach to care looks like. I can't stress enough that it really looks like excellent patient care, period. So initiating a palliative approach is much like the nursing process. There's 4 simple steps. We're going to identify patients using the surprise question. So the question is not meant to prognosticate or predict life expectancy. It's intended as an educated guess to trigger some important aspects of a care plan that incorporates a palliative approach to care. If the answer to the question is no, then a palliative care approach should be activated. The patient's situation and goals of care should be reviewed, symptoms and other needs identified, and advanced care planning should be started if it has not already been done. So this slide has an abbreviated picture of the gold standards framework, which can be used to help determine your surprise when you're using the surprise question. This slide presents a partial version, which covers cancer, neurological, renal, and respiratory, but there are also disease-specific indicators for lung disease and dementia as well. um, this and there are some general, and there are general indicators of decline to the left of that as well. The surprise question is not intended as a referral tool for specialist care either. It also doesn't suggest that palliative care is limited to the last year of life. It is simply meant to prompt an earlier activation of the palliative approach. And I'm not suggesting that all of you LPNs go forth and start telling patients they have a limited life expectancy, but there are certainly aspects of your care plan that it can address the realities of what you have identified. So I'm going to move to the assessment piece now. So assessment includes things like assessing their understanding of the illness and information needs, assessing their symptoms, their psychosocial and spiritual needs, assessing their quality of life, and their values, wishes, and preferences. And then you would move on to planning. So plan for advanced care planning, plan for goals of care and care plans, treatment plans, link them to resources and other care providers, prepare for emergencies. And then when we think about managing, we manage symptoms, we manage psychosocial and spiritual needs, we have essential conversations with patients, and we refer them for assistance as needed. There's no urgent need to do all of these things at the same time. Break it up in pieces and chip away at it. Conscientious and thorough care providers do many of these things for all patients, whether or not they are implementing a palliative approach. So, essential conversations is the last topic we're going to talk about. And I want people to know that there are no wrong things to say. What can be helpful is to understand that in general, patients with life-limiting illnesses want the following things. They want adequate pain and symptom management. They want to avoid inappropriate prolongation of dying. They want a sense of control. They don't want to feel like a burden, and they want to strengthen relationships with their loved ones. A study by Hayland et al. Asked a large number of Canadian patients at the end of life what mattered most. This information can help you in caring for patients, holding difficult discussions, or in decision making. This may not be true for every single individual because it is important to remember that every care plan is individual, but a lot of families will identify with this. So what matters most? To have trust and confidence in their healthcare providers. Not to be kept alive on life support when there's little hope for meaningful recovery. To receive honest communication about the disease. To complete things and prepare for life's end. Things like life review, resolving conflicts, saying goodbye, and they don't want to be a physical or emotional burden on their family. I'm going to go back to the first thing I listed, which was to have trust and confidence in healthcare providers. Treating patients with dignity and respect helps build trust. And to determine if patients are being treated with dignity and respect, patients ask themselves the following questions. And knowing that they ask themselves these questions, we try to make sure that the answer is yes to most of them. So the first thing, do I get help when I ask for it? Do the care providers care about me, not just for me? Are care providers courteous and respectful? Do I feel valued as an individual? Am I and my family involved when decisions are being made about my care and treatment? Do I get help to eat and drink when I need it? Do I get pain relief when I need it? Are my hygiene and continence needs met? Do I feel safe and secure? Do care providers notice when I'm upset or distressed? Just think about those things when you're caring for your patients in order to build strong, trusting relationships with them. I've got a little link at the bottom of this slide, and it's a link to a tool called the Serious Illness Conversation Guide, which is an excellent resource to help guide you through some difficult conversations. So this is what the guide looks like. Open, honest communication that addresses patients' questions directly is extremely important. And I'm not suggesting that it's a nursing job to break all the bad news and forever be emphasizing the palliative nature of the patient's disease. I think the whole healthcare team has a role in this. Physicians deliver the news, the bad news, based on lab and diagnostic test results. And when I say we, I mean nursing and other members of the interdisciplinary team, are there to clarify and support the patient as they process that information. So just some final tips and takeaways. I'm almost done, I promise. In general, not explicitly part of what I presented, I would suggest that everyone create habits that support themselves to reflect on practice, to seek feedback, and to never be afraid to try new things. And in regards to palliative care, palliative care is more than end-of-life care. It's holistic, patient and family-centered approach to care that supports patients and families throughout the illness journey. We carry past experiences, biases, and misperceptions with us, and these affect the care provided on our own and our own well-being. Culture is complex and about more than just race or religion. Take the time to ask and learn about each person's unique culture. Palliative care is everybody's business. An early implementation of a palliative approach to care leads to less depression and anxiety and better quality of life. The surprise question is a useful tool in knowing when to initiate a palliative approach, and use the serious illness conversation guide to help you navigate important conversations. Thank you so much for the opportunity to share this with you today. If there are any questions or comments, feel free to reach out to me at any time. I am completely committed to spreading knowledge about palliative care with the end goal of ensuring patients receive the best care possible, regardless of where they are. And happy Nurses Week to all of you.